had to split um, the two up here, but this is the continuation of it. So um, we were talking about the adrenal cortex hormones before. So what we're looking at here is cortisol. Okay. So one of the things I was explaining about cortisol before was that it was the stress induced hormone, and it has the ability to do many different things. Okay. One of the, and obviously depending upon what area and everything like that, if we look over here into this region right in here, you can see that, if we look at it, um, you know, you have your adipose tissue. What happens with it? You have your muscle tissue. What happens? What your liver? What happens with it? So we got to be very careful in terms of um, when we're having issues with cortisol. When is it becoming a negative problem? All right, so here's the six main things that happen. It does promote liver gluconeogenesis. We said that. Okay, that's going to be something that's going to be important for us to have because um, it's going to be able to use, it's going to be able to take the carbohydrates you need. But what are some of the other factors that happen? It degrades skeletal proteins, but that's where the gluconeogenesis comes from. So it's not always a good thing. So when we look at this, what we're saying is, oh, okay, well that's cool, but really what it's doing is it's degrading. We don't want degrading skeletal proteins. We don't want to break down muscle to be able to use it for glycogen to synthesize into glycogen and then eventually use for glucose. We don't want to do that. So we don't want that. It's a negative effect. So again, stress-induced hormone can cause problems. It does enhance lipolysis during low energy intake and prolonged moderate physical activity. That is good. We want that. Okay, we want to be able to, and lipolysis, we want to be able to break down, um, we want to be able to break down fats and oxidize fats the way we're supposed to. The problem is, like it says here, it suppresses immune system functioning. Not so good because we want to be able to have our immune system obviously function correctly. It promotes a negative calcium balance. Again, that's going to be an excitation problem. You're not being able to get excited about it. All right. And then it influences brain function, including mood changes and alterations in memory and learning. And that can be in a negative format. So we got to be very careful with the way that we look at cortisol, because typically it usually does cause negative not lasting effects but negative acute effects in the interim. So that's why a lot of times when people are stressed out they start to gain weight because they're activating things that are not supposed to be activated because cortisol is becoming rampant. Okay, so when we look at androgens, if we went back to um, let's see, I thought I had, okay, so yeah, if we look at the effects of androgens, okay, well, what are we talking about here? We're talking about um, you know sex differences, sex characteristics. This is what we're looking at in terms of androgen versus estrogen. So what are we talking about? Androgen based, more testosterone. So again, testosterone from the testes, estrogen in terms of for predominantly found in females, but we know that it can be present in males as well. But what happens with this? You're talking about increased libido, increased hair loss at the temple, increased facial hair. You're going to have a deeper voice, body hair, pubic hair, sperm production. All that stuff is going to go up. Now, if you're taking androgen synthetically, all of these can become affected, and sometimes it can start taking it into effect where you are now going in the opposite direction, which can become scary. All right. So obviously, we want to have an androgenic effect, where we actually have the testosterone do its job effectively, but we can't take into account the fact that if you overdo it, it can actually cause you to revert on some other of these factors. Okay. Looking at things pancreatic wise, this is where a majority of I think your testing information is going to come from. And the two areas that we're really going to focus in on are this term right here and this term right here, your alpha and your beta cells. Okay. Now there's things like somatostatins. Okay, and then there's other things like pancreatic polypeptides. I'm not going to get too big into those. What we're going to be focusing on is glucagon and insulin for this because you got your alpha cells, which are your glucagon, your beta cells, which are your insulin. All right, and that comes, the aisles of Langerhans. That's going to be where you're going to find, where you're going to have this differentiation in terms of the hormones that are present in those areas. All right, so there's your pancreas. All of this stuff right here is what we're looking at in terms of what's going to happen when we have issues with high and low blood sugar counts. Okay, so for our sake, in times of high blood sugar, what's going to end up happening is you're going to end up having insulin secretion from the pancreas. It's going to send out signals to that are going to allow insulin to be released into the blood. It's going to pick up the the glucose that's directly in the blood, shuttle it to the muscles and to the liver for storage purposes, and then at that point there, what it's going to do is going to basically take and decrease your blood sugar levels. Now, glucagon on the other hand detects when there is low blood sugar. Okay, and so what happens there is when glucagon realizes that there's too low, again, pancreas is, secretes glucagon, and it's going to be like, oh well, what do I need to do here? Um, it's going to pull it from, again, it's going to pull it from the liver, and it's going to shuttle it into the blood to make it so that blood glucose rises accordingly. So remember, we said there's that ebb and flow to it, and that's what we really need to pay attention to is what is that ebb and flow really doing? Are we overshooting? Are we getting it to be just right? And that's where typically, like I said, diabetics can really have a problem with that. So, what are some factors here in terms of insulin release after you eat? Well, there it is. Increased blood glucose concentration. We know that, especially if particularly if you have carbohydrates in that meal. You're going to have increased blood amino acid concentrations. We know that because you're typically having protein. All right, you have gastrointestinal tract hormones. Well, you need to because you're going to have to worry about digestion and absorption. Okay, and then there is your parasympathetic nervous system stimulation, and then your sympathetic, depending upon what's happening in those states. Are you becoming what things are becoming excited because you're eating? What things are becoming relaxed because you're eating? All right. So here's glucagon secretion. This is one of the things that we were just talking about before. What is its job? It increases blood glucose levels and stimulates liver glycogenolysis, which is basically the releasing of the recreation of new glycogen through gluconeogenesis, and then the release of it into the bloodstream, and then lipid catabolism, so a breakdown of fats. Okay, blood glucose levels. Okay, at this point here, they regulate glucagon release, and glucagon contributes to blood glucose regulation during endurance, physical activity, and starvation. And also, it's plasma amino acid stimulant glucagon release, and that's one of the things, the caveats to this. It is not just glucose that can affect glucagon. It's not just glucose that can affect insulin, and that because there are amino acids that can act kind of like carbohydrate-ish. So that's where we need to be aware of that. So for our sake here, blood glucose levels regulated. Well, yeah, because if you are low, if you are hypoglycemic, what's going to end up happening is, you're going to have glucagon released to then be able to pull it and raise blood glucose levels at that point. But remember, there is these factors that can occur where, amino acids can affect that. So it's not just glucose in particular. Okay. And this is so what happens with increased glucagon from the liver? It's going to increase glycogenolysis. So what that means is it's going to increase the new production of. It's going to decrease glycogen synthesis. So it's not going to have not turnover of like a recovery buildup. It's just going to happen where you're bringing things in, but it's going to decrease synthesis. Okay, it's going to increase gluconeogenesis or the recreation of it. It's going to increase ketone synthesis. So that can become a problem if your body can't handle enough ketones, and it's going to decrease protein breakdown. So that's pretty good. Right, kind of, but it's one of those things where it doesn't mean that one's better than the other. It's just that's the reaction that's going to occur. In fat cells or fat tissue, you're going to increase lipolysis, and you're going to decrease triglyceride synthesis. So two important factors there as well. So you're not really going to be worrying about storing anything at that point. You're going to be using. So then we get into the factors here for diabetes. What you need to understand are the difference between 1, 2, gestational, and prediabetes. Okay, we'll talk about levels in a little bit, but really we need to know the difference. So type 1 diabetes is, like it says here, the body's failure to produce insulin. So at that point there, what do we call it? We call here. Oh, whoops. All right, so we call this the ability to, you know, insulin insulin dependent. Okay, if I can type. All right, now I'll just get rid of these highlights so you can kind of see it. Type 2, on the other hand, is what we call non-insulin dependent. And that's important because it means that type 2 diabetics typically do not really require insulin. And what it is it's a relative insulin deficiency that results in hyperglycemia or high blood glucose. It's called non-insulin dependent or adult onset, whereas type 1 is insulin dependent or juvenile, because usually it happens, during early onset of that. Okay. Um, let's see. And that's really the difference between the two. So with type 2 diabetes, it's more about being on medication and trying to offset what we would call insulin resistance. We want to make you more insulin sensitive, meaning that insulin will do its job. Gestational diabetes, again, what are we talking about there? It's just it's being diabetic at with being pregnant, and like it says here, afflicts about 4% of all pregnant women. So not a high level, and out of that 4%, I don't know the exact statistics, but not a lot of those. Not a lot of females that have gestational diabetes keep the diabetic principles post baby, okay, or postpartum, okay. And then lastly, you have another one which is pre-diabetes, and that's where blood glucose levels are above normal, but they're not to a type 1 or excuse me, more of a type 2 diabetic state. And it's not high enough where usually you have to do your blood glucose testing and you end up with type 2 diabetes. That's usually with multiple tests over the period of time. Well, here we're saying that pre-diabetes is below that value. That would be, norm for what we would consider type 2 diabetes. Okay. So we hit on these two names, type 1, insulin dependent diabetes mellitus, what do we, juvenile, okay, ketosis prone, brittle, that's what you hear, whereas type 2 is non-insulin dependent diabetes mellitus, adult onset, ketosis resistant, or stable. All right, those are just some names that you'll hear, but predominantly you hear the first two of each one. Okay, you can see here age of onset. Type 1, like I said, it's juvenile. It usually happens at young ages. Type 2 typically is, as you get older. But, typically what's happening is I really think that this is really where it gets scary. Is that it says right here, increasingly prevalent in youth. So I know that I definitely test you guys on this, but one of the things you need to pay attention to is the fact that it's usually the older population, but it is becoming more readily available in children. So it's really one of those scary things where if it's becoming more prevalent in children, that means that there's something severely wrong with the way that these children are being treated in terms of their dietary and exercise habits. So it's it's one of those things where you need to be aware of everything that's going on. So that's a lot of it that can happen. So in terms of like type 1, you're looking at more viral infection, where type 2 it's more related to obesity and bad habits of living. Okay, so and the other major factor here is I think the number, I think it's like 92%, 92 or 93% of all of all diabetics are type 2, whereas I think it's like 7 or 8% is type 1. So you can see that there's a big skew in who is what type. All right. So what are the signs and symptoms? I mean, you can go through these on your own, but I would definitely pay attention to these ones right here for sure. All right, but all of these, are going to come into play in terms of, signs and symptoms for what can happen if you don't take care of the system. And but it's one of those things where it doesn't mean that it's the genetic predisposition and all that stuff. It doesn't mean it's there, but this is just some things to look at when you're if you have people who are potentially having problems where like if they are frequently urinating, if they are excessively thirsty, if they're always hungry, if they have some unexplained weight loss, if they start getting blurry vision because of the pressure buildup in their eyes, these are things that can occur that really become challenging. And so you need to, pay attention to these things, especially if you're working with people and you have some of these signs and symptoms that are occurring. So again, we just talked about genetics before. There, so what are we saying? Two factors predisposed. Yeah, there is a genetic predisposition, but there's also some environmental triggers. Environmental is going to be more type 1. There is some genetic with it as well. But the one thing that I want you to be aware of is with type 2, genetics can be potential, but it's not necessarily guaranteed because you might just have parents who are, not to be rude, but you just might have parents that are obese or over fat, and it can become a common trait within your family structure versus it being like it's passed down from generation to generation, and it could be passed down from generation to generation. It's just that it's in a different format of what we're thinking. All right, so type 2 diabetes, ethnicity wise, highest risks African Americans, Mexican Americans, and then Pima Indians. So it's a very like diverse grouping of individuals, but typically it has a lot to do with home living. How do these people cook? Pima Indians actually have the highest rate, and the Pima Indians, I believe, are out in Arizona slash like New Mexico region, so more southwestern states. Okay, so there are some ways that we need, we can test. One, obviously, the best and most important one is fasting plasma glucose. Okay, that's the one that really um, that's the one that really can get you the numbers that you need. Um, and they're the ones that will show this value right here. So let's just, so we're aware of everything. This right here, 126. So when we look at the values, if we were just to kind of put in these values to show you what is good and bad and ugly, so let me put a text box right up in here. Whoops, not there, right there. So, for a normal blood glucose, what we're saying there is usually it's less than 100. Okay. For those considered pre-diabetic, okay, what we're looking at there is about 100 to 125. And for someone to be diabetic, it's going to be, like we just said there, it's going to be greater than or equal to, because I can't do the little number there, greater than or equal to 126. Okay, now that means that when you go and get your finger stuck and you get that number thrown at you, then that is where you can definitely see if, on multiple accounts through an 8-hour fasted test, you can't be eating. It has to happen on multiple occasions. Okay, and then the other way, um, there is from everything that I've read, there's mixed opinions about what we call glycosylated hemoglobin testing or HbA1c testing. Um, that so it's said here all, but it's HbA1c. That's what it typically looks like when you're getting it done. That right there is if anything is above 6.5%, which means that 6.5% of your hemoglobin is saturated with glucose, then what that means is that your potential for type 2 diabetes is elevated, and that you would be considered type 2 diabetic. And again, that's, this is over the course of a period of time, so a little bit different at that point. So, pre-diabetic is about 5.7 to about 6.4, and anything below 5, 5.6 and below is considered to be optimal for you to not be considered in any form of diabetes, whether it be pre or type 2. Okay, so just kind of some things to think about when it comes to the testing, but definitely remember the numbers up top here. These are going to come in handy because you're going to need to remember those for when we test on it. All right. Um, so one of the things that we have to be aware of, though, when we start throwing diabetics into training, is the first thing hypoglycemia during physical activity. That's one of the things that happens, and we have to be really careful of it. Is that when we're exercising, we are using carbohydrates, which means your blood glucose is naturally going to drop. So what needs to happen is, and I've had this happen with a couple of clients of mine, where they weren't really kind of truthful about what they were eating, um, you know, during, before and during their training. And so what was happening was they were coming in and there was massive problems with there was really big problems with uh, them going hypoglycemic, and they were wondering why they were starting to feel like a little bit off, a little bit dizzy, things like that. And so you got to be aware of what they're eating, how they're monitoring what they're doing, because it can really affect them in a negative way. Okay. Um, so in terms of adding in exercise, though, like it says in the second bullet point, training to control glucose in type 1 diabetes remains complex despite the association between regular exercise or physical activity and how we become more insulin sensitive. So type 1 is a lot more challenging because of the issues that it has with insulin and how you're insulin dependent. So if there's no insulin there, then it kind of causes some havoc around the system. So we got to be aware of that. So again, can we have type 1s been able to kind of change the insulin sensitivity? Yes. Um, and that's really one of the things that need to be aware of, is that that's one of the things that needs to be paid attention to, is again, yeah, if you become more insulin sensitive, that's great, but again, it still means that there are some complications that come with it. So type 1 diabetics typically, they don't usually come off of, they need insulin, so they have to always be regulated with it. So um So again, with type 2 diabetes, what we're looking for, like I was saying before, is we're looking for insulin sensitivity. Again, we want to be able to get where we're insulin resistant. We don't want that. We need to be able to get ourselves to be insulin sensitive, where we can actually accept insulin so it can do its job. Okay, so what are we talking about over here in terms of potentials for risk? Well, retinal hemorrhaging, increased proteinuria, acceleration of microvascular lesions. It's systemically, blood based. Okay, very very difficult. Cardiovascular, you can see there's a lot of negative components there. Metabolically, yeah, increased hyper high blood sugar, and then increased ketosis, and that's not good in that state. Okay, then lastly, you're talking about because of neuropathy and the loss of nerve impulse to like extremities, foot ulcers. You can end up with limb loss, joint diseases, and eye injuries with retinopathy. Right, so all of those things can come from that. So there's a lot of negative factors that if we don't pay attention to weight management, to proper dietary patterns, that we can end up with these massive issues, not just with blood glucose, but with other areas of the body you know so it really can be a crazy crazy nightmare for people who have the condition. All right. um and so here what we're talking about in terms of again, physical activity, not just with diabetics but with just everybody in general. you know like it says here, endurance training decreases the magnitude of hormonal response to a standard physical activity level. So um what are we talking about in terms of training adaptations? That's what we're saying here. um, we already said kind of the major characteristics of what happens during specific trainings, but you can go back and look through these if you need to. Um, so let's see some major things here. Um, yeah, it just, again, it just depends on how intensive the training it really came down to. So these training responses, you can revert back to these, revert to the previous information that comes from that. In terms of like each one of the hormones and what in the area that it was. So one of the things too, after talking about hormones and everything like that, we have to be aware, of obesity and everything like that. And what ends up happening is that you get this obesity factor. Well, obesity can then turn into diabetes, type 2 diabetes. Well, from there, you have a plethora of other things that can occur. Well, look what happens, with metabolic syndrome. And this is a multifaceted, takes into multiple account many different risk factors. And if you look at it over here, we'll look at them. We already said, fasting glucose. We know that you're either pre-diabetic or diabetic if you have metabolic syndrome, or you have factors of it, of diabetes. Um, you have high blood pressure. We know it's supposed to be 120 over 80. Now we're starting to get into, um, let's see, this would be 120 over 80, 129. This right here would be considered type 1 stage 1 hypertension. HDL levels, now you're talking about being too low, and that can cause problems with, proper cholesterol and proper functioning of what cholesterol does for our system. And having too low of HDLs can start with, the early onset of atherosclerosis or a plaque buildup in your arteries. High levels of triglycerides, that's actually supposed to be below 150 as the value. And then your waist circumference above 40 and above 35 for, males and females. And that's really where you're starting to see all these conglomerate of factors coming into play. And you end up with a problem where you have this multifaceted, really hard to, um, really hard to kind of take care of effect, because it's just horrible, you know. So you got to be aware of that at all costs. Um, so in terms of, there, we kind of hit on growth hormone earlier, and with training, you can see, and we said that with training, it starts to rise after the first few minutes of training, and as the intensity picks up, you have high levels of growth hormone that start coming into play. So, we got to be aware that um, there, it's important for us to have, and it rises accordingly, but then it comes back down to resting values. So, we need it to do what its job is during the time frame. But then, if you look over here, though, in our diagram, you can see that week 3 and then post, um, we're actually diminishing our growth hormone account. So if you look, growth hormone concentration during 20 minutes of constant load exercise and 45 minutes of recovery at pre-training, after 3 weeks, and then 6 weeks. And then if you saw, it's about a 45% decrease than pre-training values. So you got to be aware of, what really is happening with growth hormone at this point, and is it really with long-term training, are we actually training the right way to make it enhanced? Okay. Um, with your anterior pituitary, again, your hormones for training, your corticotropic hormones. Training increases ACTH levels, corticotropin, levels. So what to do? Enhance fatty acid oxidation. That's great. We want that. We want to be able to break down fats to really, supply either energy or to just be burned off, and to help us diminish our fat stores. Okay. Prolactin, really not much in terms of what happens with long-term training. Um, Testosterone, uh, follicle stimulating and luteinizing hormone. What we're saying here, regular physical activity depresses reproductive hormone responses in women and men. So that can, long term wise, it can obviously change hormonal production. It depresses reproductive hormone responses. So that can too much can really cause massive influences. And we don't, not necessarily mean we're not going to train. It just means that we have to be able to train correctly to be able to offset that. Antidiuretic hormones, there really isn't much difference in terms of the response. Oxytocin, and what this is there with arginine, vasopressin, increases following prolonged endurance. Well, we know that it's an antidiuretic base. So what we're doing is holding, we're able to mess around with fluid retention and making sure that we're properly, hydration becomes a little bit easier. Um, we know that with thyroid hormones, that if we enhance our exercise, we have the ability to be able to, you know, to change the function of our thyroid slightly, not to the greatest extent, but enough where, um, it can really set us up to be okay, where we can basically have a little bit more. It says here with mildly depressed thyroid function, we can actually enhance the ability for the thyroid to function correctly. Um, with aldosterone, again, kind of going back to that chart, really not much a training effect with that. In terms of, we said that that's more like an androgen response. Um, Cortisol, plasma cortisol levels increase less in trained than sedentary. So that means that, you know, you're going to produce the same amount. You're not going to get rid of it. But remember, cortisol is also really important for proper weight management and everything like that. But our body is able to tolerate more as well. All right. And then lastly, with epinephrine, norepinephrine, you know, you're able to get more norepinephrine, which is really the true adrenaline at this point, to be able to work well and kind of be staying in that fight or flight, that stress response, which is okay. All right, and you can see here, look what happens in terms of your charting as you increase your percentage of your VO2 max. What's actually happening with the amount of epinephrine, norepinephrine for pre-training versus post-training at specific levels. So it's really important to see that it really is going to get you into a better sympathetic state and be able to get you to function correctly, especially like I said with norepinephrine. And insulin and glucagon, it just again you're going to be able to function these hormones better. Okay, so trained state requires less insulin at any stage. Becoming more insulin sensitive, you don't need as much. You can work with a little bit better. And there's two mechanisms that explain why this training response is really good, and that's because it says right here increased muscle and fat tissue sensitivity to insulin. So that means that you know you're changing your body composition, so therefore becoming more sensitive to insulin. And at that point, you're able to accept it, a lot easier, and you're able to store and remove, or vice versa, depending upon what you're doing. All right. And then an increased percentage contribution of fat catabolism for fuel during submax physical activity. What we're saying here is that if we can get insulin and glucagon to work correctly, you're not going to start pulling all these carbohydrates or glucose as needed. So what we're going to do is we're actually going to be able to break down fat and not just settle only in for carbs. We want to be able to, we want to be able to function and break down fat so we don't have it stored. We want to be able to use it, okay, which is great, which is really a good process to have because insulin is better regulated. All right, and so what are we talking about again with endocrine function? If you look here, if you're gonna do heavy resistance training, it's gonna release the proper It's gonna have proper hormonal balance, which transports everything better, which basically means you have better receptor interaction, which means that cellular effects happen at a quicker rate, that adapt cells quicker. And at that point there, what do you end up having happen? Increased force production, and therefore you have increased strength and power. So that's how it happens. It's not just that it's just muscle just gets bigger, or muscle gets stronger or more powerful. You have hormonal responses that create these effects, and therefore end up with the byproduct of heavy resistance training increases strength and power, but it starts hormonally and then works its way all the way through. All right, and then lastly, in terms of opioid peptides, we're talking about endorphins. Like people say that like running has that runner's high approach, and you end up with that like a euphoric feeling like you would with like if you were to take a drug or anything like that. But one of the cool things about endorphins is right down here. It says endorphins regulate menstruation. Women who say that they exercise during their menstruation or their menstrual cycle, they have an ability to feel a little bit better. It can help with like cramping and things like that. It just makes them feel a little bit more at ease. Again, I'm not a female, so I can't give you any firsthand knowledge on that, but that's what I've been told and what I've seen in research and literature. All right, and then it helps regulate other hormones as well. So endorphins can help with, corticotropins, catecholamines, which again, norepinephrine, epinephrine, acetylcholine, and then cortisol. Okay, so definitely a really good effect where you're definitely going to have this more of a better feeling of everything versus feeling crappy. So but this is the hormone chapter. I'm going to put this up, and everybody's going to see this. And then because we're going to be having our review for our testing, this is definitely going to help us in terms of understanding what major components you want to study from this chapter to be able to help you with your testing on Monday. So everybody have a good night, and we'll talk to you soon.